Welcome, everyone, and welcome to our conference session titled Living with Low Risk MDS. Thank you for joining us. My name is Alice Hauk. I'm the Senior Director of Patient and Professional Services at the Aplastic Anemia and MDS International Foundation, and I'll be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. If you are participating online, please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you finish typing your question, hit enter. We'll do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help me manage the incoming questions. Submit your entire question all at the same time, and please do not share private health information in your question. Our speakers cannot answer any specific questions related to your health care. This session's speaker is Amanda Przespolewski. Dr. Przespolewski is an assistant professor who joined the leukemia service within the Department of Medicine at Roswell Park in July 2017. She treats patients with both malignant and non-malignant blood disorders. This includes patients with acute myeloid leukemia, myelodysplastic syndromes, chronic myeloid leukemia, and myeloproliferative neoplasms. As a native of Buffalo, she completed a portion of her training locally, receiving her doctoral degree from the Lake Erie College of Osteopathic Medicine, and she completed her residency in internal medicine and fellowship in hematology and medical oncology through the University of Buffalo. Dr. Przespolewski also holds board certifications in internal medicine, hematology, and medical oncology. Her research interests include early phase clinical trials for high-risk myeloid malignancies, as well as translational medicine. Her translational work is focused on understanding how leukemic blasts modulate the local immune system to evade detection and therefore identifying new therapeutic targets. Welcome, Dr. Przespolewski. Thank you.
Hello, everyone. I'd like to start out by thanking the meeting organizers for the invitation to speak with you all today. So as mentioned today, my topic to share with you is living with low-risk myelodysplastic syndrome. And these are my disclosures. So today we're going to cover a few things. I wanted to start out by describing what exactly is myelodysplastic syndrome with an overview. I'd also like to share with you some of the symptoms when they have this condition, as well as how we go about diagnosing and what we call risk stratifying this disease. We will also be covering how and when patients with myelodysplastic syndrome should be treated, as well as some novel therapeutic options that are coming to light for patients with MDS. So myelodysplastic syndrome is considered a cancer of the immature blood cells within the bone marrow. This cancer then results in the abnormal appearance, function, and production of blood cells, including white blood cells, red blood cells, and platelets. In adults, the majority of the bone marrow where this blood cell production takes place resides within the flat bones, such as the sternum and the pelvis. These bones are comprised of a hard outer layer known as the cortical bone, and within the center of the bone resides the spongy marrow, which is where the blood cells are produced. This marrow space will eventually result in the production of red blood cells, white blood cells, and platelets. And then with the vasculature that you can see here, these blood vessels then take these newly made cells out to the systemic circulation to carry out their ultimate function. Hematopoiesis is an important item that should be understood to really get a grasp upon how myelodysplastic syndrome affects patients and their blood counts. So the process of what we call hematopoiesis is basically representing the production of red cells, white cells, and platelets. So what happens is within our bone marrow, we all are born with a certain amount of stem cells that can give rise to these more mature blood cells. And as those stem cells make copies of themselves, they then differentiate and mature, becoming healthy red cells, healthy white cells, and healthy platelets. But unfortunately, in patients with MDS, this process does not occur appropriately. So to further illustrate hematopoiesis and its process, I wanted to go with the analogy of a closet. So you can see on the left-hand side would be your dream California closet, very well organized. You can see everything that's in there, including shirts, pants, shoes. So you could put together an outfit pretty quickly with how that's organized. However, on the right-hand side, this closet is quite messy and dysfunctional and looks like my office after a week of covering our inpatient service. So you can see here, it's really difficult to make out what is exactly in the closet and whether or not we even have essential items to put together an outfit like shoes or pants. So this is similar to ineffective hematopoiesis in patients with MDS because the dysfunction caused by the cancer within the bone marrow, it renders it to ineffectively produce red cells, white cells, and platelets. So how do patients with MDS present to us in clinic? I would say some patients are what we call asymptomatic. So they feel completely fine, but for example, went to the emergency room with some stomach pain and the doctor, when doing standard tests, found low blood counts. Alternatively, I have patients that are referred from their primary care doctor performing standard of care complete blood counts, and we identify some lower numbers. Some patients present to their doctor complaining of fatigue or tiredness, and oftentimes this can be a result of the cancer itself or from the low red blood cells, also known as anemia. Similarly, patients can present with weakness. Usually it's generalized, just that they don't feel up to doing things and may not be able to carry out their everyday functions. And this can also be a result from the cancer itself or from anemia. Patients can also present with easy bruising or bleeding because sometimes patients have low platelet counts, but sometimes we see this in patients with low normal or even normal platelets because they don't function properly as a result of the MDS. And lastly, some patients can also present with infections because this cancer can impact your immune system, which produces white cells, and these can either be low or dysfunctional, resulting in recurrent or frequent infections. So what do we see when we check patients' labs? We standardly perform a complete blood count with a differential, and sometimes we can see a low white blood cell count, which we refer to as leukopenia. Some patients can present with a low or normal white blood cell count but have a low absolute neutrophil count, which is kind of a subset of a total white blood cell count, and we refer to that as neutropenia. Some patients, as I mentioned, can present with a low red count, also known as anemia, as well as thrombocytopenia, which reflects a low platelet count. So what ultimately causes patients to come down with myelodysplastic syndrome? We feel that this is due to genetic mutations that are present within those immature stem cells. And these mutations essentially prohibit the stem cell from carrying out its normal function, which is to grow healthy blood cells, and instead grows abnormally and prevents the normal production of blood cells. Myelodysplastic syndrome and these genetic changes are often associated with increasing age and exposures to toxins such as chemotherapy that is sometimes given for other cancers, radiation treatment, benzene exposure, as well as tobacco use. In addition, other disorders such as aplastic anemia and paroxysmal nocturnal hemoglobinuria, or PNH, can sometimes evolve into a myelodysplastic syndrome. And lastly, there are certain conditions that patients can be born with and can inherit from their family members that can ultimately result in a myelodysplastic syndrome, such as Fanconi anemia, as well as other mutations such as a GATA2 deficiency, DDX41, and Anchor D26 deficiency. And because of these conditions coming to light, It's very important that you discuss your family history with your provider because this can potentially impact your treatment, and this is also important for your relatives as well. So the epidemiology of myelodysplastic syndrome is that it mainly occurs in older adults. The median age when patients come down with this condition is about 76. Overall, we see approximately 5.3 to 13.1 cases per 100,000 people, and in patients that are older, above the age of 65, we typically see between 75 to 162 cases per 100,000 people, reflecting the increased incidence with advanced age. The prevalence of this disease ranges between 60 to 170,000 cases within the United States. So how do we go about diagnosing this condition? Patients may be familiar with this procedure called a bone marrow aspiration and biopsy because this procedure allows us to take material directly from that hematopoietic space within the bone marrow to look at these stem cell precursors and identify what the cause of the patient's symptoms and/or blood counts are. So this procedure is typically done in the office setting with local anesthetic. However, some patients may have a lower pain tolerance, so it's completely acceptable to offer sedation for these types of procedures. So once the patient is cleaned, we use local anesthetic as well as light sedation if the patient requests it, to essentially insert a needle through the hard cortical bone into the marrow space to then perform what we call an aspiration, which is when we actually draw fluid with a syringe from the needle and send that to the lab for analysis. And then we also will reposition the needle and then take a small piece of the bone, also known as a biopsy, and send that for testing. So to review some of the testing that should be standardly performed on a patient's bone marrow biopsy and aspirate, I have several of them here to go over with you. So first on the top left is morphology. So basically what that means is the pathologist will look at both the liquid aspirate as well as the piece of the biopsy under the microscope. And this piece is important because we need to understand what these precursors look like, what their shape and size is, because that can lead to the diagnosis. We also assess for a certain population of cells called blasts. And those cells are important because we track them as patients are with us because they can indicate what risk level patients have with their disease, as well as what treatment we should offer them. And to the right of that, you can see an example of a test called flow cytometry. So we perform this test on the bone marrow aspirate, and essentially it helps us further characterize what is the makeup of the cells within the bone marrow, because that can aid in the diagnosis and sometimes can also further clarify how many of those blast cells we see within the bone marrow space. Next, we'll move on some important genetic testing that should be done on your bone marrow biopsy and aspirate. The first two tests on the left and in the middle reflect a procedure called cytogenetics, as well as another test called FISH, or fluorescence in situ hybridization. And this test looks at the genetics of your cancer cells almost from the 40,000 mile up space. So this gives us an overview of what the entire chromosome looks like. And in patients with myelodysplastic syndrome, sometimes we can see pieces of chromosomes that are missing or duplicated, as well as sometimes even complete loss of a chromosome. And we can confirm those findings with this FISH test, and that's important because some of these findings that we can observe can not only confirm the diagnosis of myelodysplastic syndrome, but also provide important information about prognosis for the patient. And the last test that's become more standard over the last 5 to 7 years is something called molecular testing. So whereas the cytogenetics and FISH give us a bird's eye view of the genome, the molecular testing will actually go to the individual minute gene level to evaluate genes that are important in prognosis. So this gives us more granular detail regarding the cancer and how we would expect it to behave over time. So to officially make the diagnosis of myelodysplastic syndrome, we need to meet several criteria. First, we would look to see whether or not the patient has any what we call cytopenias or low blood count based on a complete blood count assessment. So if a patient has either a hemoglobin less than 11, an absolute neutrophil count less than 1.5, or platelets less than 100,000, that would be one part of the criteria that's met. The second criteria that needs to be met, which are decisive for MDS, includes greater than 10% dysplasia observed within the bone marrow in one or more lineages. So what that means is when a stem cell goes on to be a little bit more mature, it would either be a red cell precursor, a white cell precursor, or a platelet precursor. So eventually destined to become one of those three cells. And we look at the dysplasia, or how abnormal those precursors look under the microscope, and the pathologist can give us a percentage based on the total number of cells. So to meet the criteria of MDS, if we're looking at dysplasia, patients need to have more than 10% dysplastic cells in one of those lineages. Or if we identify between 5 to 19% blasts, that would fit for this criteria that's needed. Or if based on the karyotype or cytogenetics, some of the mutations that we can find in cytogenetics are particularly found in myelodysplastic syndrome and can sometimes seal the diagnosis on their own, as well as evidence of what we call clonality, which basically means cells are the same, and we typically see that in cancerous processes, whereas healthy cells usually look different. Lastly, what if we've met those two criteria, we need to ensure that we've ruled out all other causes of dysplasia under the microscope or causes of low blood counts. So one of the common tests that patients typically should undergo if we find that their blood counts are low is to look for B12 or folate deficiency. Because if patients have deficiencies in those vitamins, that can cause low red blood count, low white count, and low platelets. So that should be tested for. In addition, one of the more rare micronutrients, copper, if patients are low in this, that can also cause low blood counts. In addition, we typically assess for viral infections such as hepatitis, HIV, as well as cytomegalovirus and Epstein-Barr virus, because that can affect the blood counts if a patient has an infection. One of the toxins that we typically assess for when we meet for a patient is whether or not they use alcohol, because heavy alcohol use can impact how the bone marrow looks under the microscope, as well as can lower blood counts. In addition, there are certain medications that can lower blood counts, so your physician or the practice pharmacist should perform a thorough medication history. And in addition, patients with certain autoimmune conditions can have low blood counts as well as dysplasia. So now to get to the risk stratification. So this is important because in this type of blood cancer, we don't have a staging system similar to what patients with lung cancer or colon cancer might have, a stage 1, 2, 3, or 4, which in those tumors, it's important for treatment decisions and prognosis. So in patients with blood cancers, we look at several different factors that will help predict how the patients will do long term. So the factors that are taken into account that tell us prognosis are several things. First, we look at the blood counts. How many of the blood counts are low and how low are they? We also take into account the blast percentage, because the higher that blast percentage is, the closer it gets to 20%, the higher the risk of the disease and the shorter the time that we would expect to transform to a more aggressive disease called acute myeloid leukemia. And lastly, we're incorporating the genetic information to this risk stratification. So we're looking at both the cytogenetics and the molecular profile of the cancer to tell us how patients will do long term. Now, to put all of these variables together, it is quite a complicated calculation. So many services have put together an online calculator that you could even look for yourself once you have the information from your doctor to confirm your risk stratification. So as you can see, patients that have very low risk disease usually go on to die of other causes. Whereas patients that have higher risk disease and higher risk features, unfortunately, they can have a shorter time to progress to an acute leukemia and can also have a shorter survival. So that's why it's important to identify what patients' risks are, because, for example, if someone is high risk, the doctor would want to move quickly on treating that patient if they were appropriate for it, as well as looking into curative therapy for those patients on a more fast basis. So treatment. I think there are several things that both patients and providers should consider when deciding on a treatment plan for a patient. First should be, what are the treatment goals for the patient and for their family? Are they somebody who is very fit and very active and was an avid runner and would like to get back to their athleticism? Or are we evaluating a more elderly patient that may have a harder time getting out of their house and is prioritizing quality of life? So quality of life is one of the factors that we can control for. And I think that's important to take into account in treatment because some of the treatments that doctors can offer can negatively affect quality of life. And in some patients, that being a bigger priority as opposed to trying to identify a treatment that could help them live longer. In addition, it's important to take into account what is important to the patient. What are their beliefs? What are their values? And what kind of support do they have? Do they have a large support network that could help take them to and from appointments, to and from treatments, to check in on them if they become ill? Or is this somebody who maybe doesn't have a lot of family or friends around that could be at risk for complications if no one's checking in on them, or maybe at risk for making appointments if they don't have a ride? However, there are some factors that unfortunately we can't control for that can impact treatment. For example, somebody's age, how fit they are, and what other medical problems do they have? Are they somebody who's fairly healthy and has never been on any medicine their entire life? Or is this somebody that had a heart attack and a bypass and has lung disease from smoking? So that can impact how fit a patient is and what kind of treatments they can tolerate. Lastly, the risk stratification of the patient is important to determine a treatment. So with this slide, I just wanted to provide a brief overview of the treatment algorithm for patients with MDS. So first and above all, I believe that all patients should be considered for clinical trials, irrespective of their disease status and their risk stratification, because clinical trials offer the ability of providers to deliver first-in-class therapy to patients years prior to these therapies becoming approved. In addition, all patients, irrespective of what kind of treatment they're having, should also be given supportive care, and we'll get into that in a little bit. And lastly, as I've tried to emphasize, the risk stratification, which now we're using molecular testing, so the official name of the risk stratification system is the IPSS-M. That should be performed, and as you can see here, patients that are lower risk are treated differently compared to patients that have higher risk disease. So overall, the treatment options that we have include watchful waiting, supportive care, which as I mentioned is applicable to all patients, growth factor support, lenalidomide, immunosuppressive therapy, as well as hypomethylating therapy. So with regards to the watch and wait approach, this is typically for patients that have mild decreases in their blood counts and are symptom-free. I also use this approach for patients that if they were in a situation where any treatment could potentially cause more side effects than the symptoms they presently have, they would be a better candidate for observation. This could possibly be a more elderly and frail patient. So for this patient population, I recommend a complete blood count with a differential at least every 3 to 6 months. Some factors to consider in how often you're following low-risk patients would be what their molecular and cytogenetics are, because I've had patients with low-risk disease, but with some high-risk cytogenetic features that are at risk for progressing to a higher grade myelodysplastic syndrome or an acute myeloid leukemia more quickly. Those patients, I would argue, should be followed at least every 1 to 2 of their blood counts. So supportive care, which is applicable to all patients with myelodysplastic syndrome, is very important. Some of the elements to supportive care include blood transfusions, and typically our practice here at Roswell Park is to transfuse if patients have a hemoglobin less than 8. However, unfortunately, with the pandemic in the last 3 years, we've had a decrease in our blood donors, which has impacted the supply of critically short blood types such as O. So for those patients, sometimes we are not able to offer blood transfusion simply because of the lack of products, so we have to use a lower threshold. So this would be a plug for family and friends to go donate blood. It's a very precious gift. Another therapy that can be considered for supportive care is something called iron chelation, which we'll get to in a little bit. I also recommend preventative medications for patients that are what are called neutropenic to prevent infection. And we typically use antibiotics in this situation, and some patients we also choose to use antiviral treatment as well as antifungus treatment because patients with low immune systems unfortunately are vulnerable to all of those infections. Lastly, I strongly recommend patients receive all of the recommended vaccines. With regard to iron chelation therapy, unfortunately, patients that have a high transfusion burden, meaning they come for blood transfusions perhaps 1 to 2 times a week because of their severe anemia, can be at risk for iron accumulation within organs such as the heart and the liver, which can result in organ damage. Unfortunately, there's not a lot of data to support the use of iron chelation in terms of what we would consider robust clinical trials. Therefore, this should be considered with each patient individually because there are a fair amount of side effects with these kinds of medicines that can negatively impact patients. So the study that I have here to discuss with you is the only what we call prospective, so best level evidence of using iron chelation in patients with MDS. However, unfortunately, this trial was sought with a variety of problems. They were not able to accrue the number of patients, so essentially had to downsize the trial, which can impact how statistically significant the results are. So with the study, they randomized patients to get a placebo or to get treatment to bind their iron to get it out of the blood and out of the organs to prevent this damage. So when they did that, they saw approximately a 35% reduction in what's called event-free survival. So what that means is about 35% of people they found had a reduction in the chances that they experienced organ damage from excessive transfusions. However, as I mentioned, there are a fair amount of limitations to the study. So as I said, there's not a lot of strong evidence to support this in every patient. So some of the side effects that we can see with this iron chelation therapy include pretty severe diarrhea as well as kidney injury. So in patients that are older, I often don't recommend this because it can often worsen kidney function in that patient population. I feel that this type of therapy is better warranted in a younger patient with a very heavy transfusion burden. So now to get into growth factor support that can be looked at as a treatment option. So there are several different types that we'll discuss today. The first two are the erythropoietin agonists, erythropoietin alpha and darbepoetin alpha, and we'll also be covering granulocyte colony stimulating factor. So the erythropoiesis stimulating agents are basically a class of drugs that provide exogenous or external erythropoietin hormone, which is important and should be in high concentrations in the setting of anemia to tell the bone marrow essentially to make more red blood cells and to respond to that anemia. So patients that would be eligible for a treatment of this type should have symptomatic anemia prior to receiving any blood transfusions. We also expect that patients have a better chance of response on therapy if they have what we call a lower transfusion burden using less than 2 units a month, and they also do better if their erythropoietin level at baseline is less than 500. However, if patients only meet one of those criteria, they would have expected a 25% chance of responding to a treatment in that class, whereas patients that meet both of those criteria can respond up to 75% of the time. And as I mentioned, this is hormone that's given to patients to stimulate the bone marrow to increase production of red blood cells. There are some patients that may be on this type of therapy and it may stop working at one point. So a study was done to see if we could continue using that medication but try and rescue it with another agent called lenalidomide to see whether or not this could improve anemia in patients. So this trial was conducted in 2008 and it evaluated patients with lower risk MDS, and they were characterized as low and intermediate 1 by the old IPSS scoring system. Patients on this study could not have had deletion 5q, and they had to show that they were dependent on transfusions with greater than or equal to 4 units of packed red blood cells over an 8-week period prior to getting randomization. And they also had to show that they were no longer responding to the erythropoietin stimulating agents over 12 consecutive weeks, and they had to have been getting an adequate dose of those agents. So patients underwent what's called randomization, and they were decided to either receive this drug lenalidomide by itself or this drug lenalidomide in combination with the erythropoietin agonist that they were previously on. So this drug lenalidomide is a pill that's given at 10 milligram doses daily for 3 weeks with 1 week off. And it's given the same way in combination with the erythropoietin agonist. And patients were treated on this study until they relapsed. So the results of this study, after evaluating 132 patients, showed that the combination of the erythropoietin stimulating agonist as well as lenalidomide resulted in a significant increase in red blood cell counts, which resulted in 24% of patients achieving independence from transfusions, meaning they no longer needed them for their anemia, versus 14% of patients who were treated with lenalidomide itself. So one of the new drugs that we were excited about and has come to market over the last couple of years is a medication called luspatercept. This is a first-in-class, what we call erythroid maturation agent. And essentially, it helps the red blood cell precursors grow up to become healthy red blood cells. And it works by blocking aberrant signaling in a pathway called SMAD2 and 3, to basically further enhance the later stages of red blood cell production. So the study that evaluated this drug and led to its FDA approval is called the Medalist study. So this study enrolled patients that were 18 years of age or older that did not have a deletion 5q MDS and ring sideroblasts per the WHO 2016 criteria. As well as they had to have had very low, or intermediate risk disease per the older IPSS revised classification. They also had to be refractory, intolerant, or ineligible for erythropoietin stimulating agonists. And they also had to demonstrate that they were transfusion dependent on red blood cells. So patients were randomized to either receive luspatercept, which is given as an injection every 3 weeks for 24 weeks, versus a placebo. And patients were continued on this treatment until a lack of clinical benefit or progressive disease was observed. The findings of this trial demonstrated that luspatercept significantly reduced the burden of red blood cell transfusion compared to placebo in patients that had true transfusion dependent, very low to intermediate risk MDS, a subset with ring sideroblasts. Treatment was generally well tolerated, and as I mentioned, this drug was recently approved by the FDA in 2020 for patients with very low to intermediate risk MDS with transfusion-dependent anemia failing an erythropoietin stimulating agent in patients with myelodysplasia with ring sideroblasts, as well as MDS or MPN with ring sideroblasts and thrombocytosis. So a little bit about GCSF. One of the names of this drug is often filgrastim, and it's indicated, and I think in very select situations where patients have severe neutropenia or low absolute neutrophil count, and or recurrent infections. However, there's not a lot of data on how this agent modifies the disease history in terms of whether or not it improves survival for patients with these blood counts in this condition. We don't have any information on how it impacts transformation to acute myeloid leukemia or how well it prevents infections. So it does have, I feel, a very limited use. Another agent that I'll briefly discuss, and we did discuss earlier, is lenalidomide. So outside of the clinical trial that we discussed, it is indicated in patients with transfusion-dependent anemia, and it is also indicated in patients that have deletion of 5q on cytogenetics in FISH, with or without additional cytogenetic changes. And this drug works by essentially directly destroying the abnormal cancer cells within the bone marrow, but it's also considered what we call an immunomodulatory agent. And that's important because we feel the immune system does have an important job to essentially prevent cancers from growing and to get rid of abnormal cells if they're present. So this drug has been shown to enhance the activity of the immune system against cancers. Immunosuppressive therapy is appropriate for a very specific subset of patients with low-risk MDS. The types of therapy that we use in this situation are anti-thymocyte globulin, as well as cyclosporin, which both work in slightly different ways to suppress the immune system. And this is important because in patients that are appropriate for this, under the microscope, they often have what's called hypocellular MDS, meaning there's not a lot of healthy cells within their bone marrow. And this condition is similar to another condition that's being discussed today, aplastic anemia. So they are treated similarly with medicine to suppress the immune system because we feel in these particular cases, the immune system is responsible for the changes in blood counts as opposed to a more cancerous process crowding out the bone marrow. So patients that would be appropriate for this are typically younger. We do HLA typing on these patients, and if they're found to have a DR15 positivity, they do respond better to immunosuppressive therapy. Lastly, patients that have a clone of paroxysmal nocturnal hemoglobinuria are also expected to respond better to immunosuppressive therapy. I won't talk too much about hypomethylating agents as my colleague Dr. Eunice Wang likely extensively covered them. However, there is a role for this particular type of therapy in patients with low-risk MDS. Typically, I use this agent in patients that have failed first-line therapies, such as the ones we've recently covered. So some of the things that are in the pipeline and we hope to see in the near future are drugs that are more targeted for cancer changes that are specific to MDS. So we've already discussed luspatercept, which was recently approved. We are evaluating a thrombopoietin agonist, and that is essentially a hormone that stimulates the bone marrow to make additional platelets. And there are 3 formulations of that type of drug. However, right now, we don't have enough clear evidence as to the benefit that we would expect to have in patients with MDS and whether or not it impacts outcomes. So there's more to be determined with that. We're also looking at the targeted agents called IDH inhibitors, and these drugs are specific to patients that have an IDH 1 or 2 mutation on their molecular testing. And this drug basically reverses a cancer toxin cause and pathway that results in restoration of healthy production of red blood cells. So one of the last things I wanted to leave you with is the clinical trials website. So the website is www.clinicaltrials.gov. And I encourage patients and their families to search for clinical trials near you. As I mentioned, participating in a clinical trial not only offers novel treatments to our patients, but it also advances the field. I also encourage patients and their families to take note and use of several resources that are widely available. First is the Aplastic Anemia and MDS International Association, as well as the Leukemia and Lymphoma Society and the MDS Foundation that can offer resources, possibly such as grants, as well as information about the disease for patients and their families, and they are a large support of networking for patients. In addition, I put the National Comprehensive Cancer Network here, as this is a website that most providers should be using to pull the latest evidence-based recommendations for treatments for patients with myelodysplastic syndrome. They also have a very nice section for patients that goes over these, but encourage patients and their families to take use of these resources. And lastly, some of the takeaway points that I hope you leave with from this lecture are to be an informed patient. You should be knowing what your risk stratification is, what your risk group is, and make sure that you understand your treatment options. I would encourage you to define for yourself what your treatment goals are and to have a candid discussion with your provider about those goals. I also hope that you use some of the resources I've shared with you and make sure that you surround yourself with caregivers. And now I'll stop for questions. Thank you.
Thank you. If anyone in the room has any questions, I can bring the microphone to you. We have a couple from online. One is with MDS del(5q, when Eprex has failed and the person is on Revlimid, if this fails, what other drugs can be taken? Perhaps a study one can go on, or and also with del(5q and del(11q), how do these deletions affect someone? So it's kind of a two-part question.
Sure. So for the first question, so when patients have failed 2 lines of therapy, it's important to understand what their disease profile looks like, because as I mentioned, there are some drugs that are targeted depending on the certain mutations that are present in the patient's cancer. So if they're failing therapy, the provider should repeat a bone marrow biopsy to ensure that they have the latest and most updated understanding of the changes within the bone marrow, that at that point could offer options for clinical trials with targeted agents. We have clinical trials with immune-based treatments for those patients. They could also be considered for standard of care hypomethylating agents, either at a full or a reduced dose. And the question was regarding the impact of the second part?
Del(5q) and del(11q), how do those deletions affect someone?
So those deletions are commonly seen in patients with myelodysplastic syndrome, and the effect that it would have on someone would be dependent on what the rest of the genetic changes are within the bone marrow. It's also dependent on what the blast percentage is, as well as what the molecular profile is, because those changes, unfortunately, don't act by themselves. They act in concert with what the rest of the disease looks like.
Thank you. And now we have a few questions related to luspatercept. Luspatercept for patients who previously have had an ischemic stroke. And we'll take one at a time, sorry. There are a few other questions.
Sure, so I think it would depend on the functionality of the patient that had the stroke. I think it would depend on how fit they are. Are they debilitated from the stroke? It would depend on how well their blood pressure was controlled. It would also depend on what areas of the brain the stroke affected. There's a lot of things that should be taken into account to decide whether or not that's an appropriate therapy for a patient.
And also related to luspatercept, does this drug cause or make patients experience severe gastrointestinal symptoms?
It can be associated with some side effects such as that.
Okay. And at what hemoglobin number does your practice stop administering the drug for a while?
So I think it depends on the patient and where they are in terms of their counts, and it also depends on how they're feeling. I have some patients that feel better with a 1 gram increase in their hemoglobin, and I have some patients who really haven't had much of a change in their counts, but they say that they feel improved on the agent. So it really depends on the individual patient and what their transfusion parameters are.
And here's a somewhat more detailed example. If the patient's hemoglobin on luspatercept rose to 10.5, but is now fluctuating between 9.4 and 9.7, would you still maintain the same dosage of the drug, or would you increase the drug dosage, or leave it as is with the original dose?
So unless the patient is being a higher threshold, that seems like a fairly small fluctuation. You said they were at 10.5?
Yes.
Okay. So I think it depends on how the patient's feeling on the medication, and what the transfusion parameters are. If this patient is feeling well, then I would probably not increase the dose. But if they were, say, for whatever reason, being transfused for a hemoglobin of 10, then it might make sense to go up on the dose. But we typically don't transfuse patients that high. I've only seen it very rarely in exceptional circumstances.
Thank you. What would you suggest patients do when they feel that they're experiencing side effects that perhaps they may not think they're important to report, or perhaps it may be something that wasn't expected on a particular medication, but if they're experiencing any side effects, how do you recommend patients deal with them and report them to you or your colleagues?
Sure. So I think each patient is different, and each patient has different symptoms either from their disease or, side effects from the medications that they're prescribed. So it's really hard to give patients kind of an overview of what to expect because everybody's different. So I personally tell my patients that I would expect that they call me with anything that's new or different, because it's important to determine, is that a side effect of the drug, or is their disease progressing? Do I need to be worried about that? Or is this a problem because of the MDS? For example, an infection. So I usually encourage patients to call their hematologist if they have anything new or different.
Thank you. And as far as clinical trials go, you spoke about that during your presentation as well. There are many clinical trials for low-risk MDS as well, right? If they are not offered to a patient in their meetings with the physician or their healthcare team, should patients ask the question about them?
Absolutely. So that's why I provided the clinicaltrials.gov website. So patients can be informed, they can be educated, they can know what's out there. And we do have a clinical trial that we actually were one of the highest accruing sites, meaning we put the most patients on it, for a lower dose oral version of decitabine for patients with lower risk MDS. And like I mentioned, there's immunotherapies, targeted therapies that are coming out for patients. So that's why it's really important for patients to take the wheel and be knowledgeable about the disease and the treatments.
Any other questions from inside the room?
Beyond pharmaceuticals, any recommendations for alternative or complementary therapies to support the immune system?
Sure. So I do get that question fairly often. So I would encourage patients in general to have a healthy diet. So to make sure that, we are getting 5 servings of fruits and vegetables, because those antioxidants, the protein that you get, the carbs are all very, there aren't any particular supplements that I found that can improve patients' either symptoms or quality of life significantly. But if you do choose to look at supplements and things like that, I would encourage you to discuss that with the pharmacist at the practice or the physician, just to make sure some of those supplements don't interact with the medications that the doctor might have you on. I also encourage patients to exercise because that ensures that you're fit, you have good blood flow, and to really give the bone marrow the workout that it needs to produce healthy blood cells.
I noticed, and I'm not sure if it was your presentation, doctor, or the previous one, that the lenalidomide was 21 days on, 7 days off. But now we're dealing with a full month. Has that strategy changed?
No, so it's dependent on what situation you use it in. So I would say it's not very common for us to use the lenalidomide in a situation where it's given for 21 days on and 1 week off. In the situation of giving it in somebody who is on the erythropoietin stimulating agent, so like the growth factor shot. So it's given like that in that particular situation. Otherwise, for the rest of the patients, we do it continuously. That's a good question.
We have another online question. Do fibromyalgia medications cause problems for patients with low risk MDS?
Typically, though, the medications that are used for pain in that situation shouldn't impact blood counts and shouldn't interfere with any treatment that your doctor would recommend.
Thank you. And you spoke about quality of life considerations during your talk. how do you interact with patients who are having difficulty dealing with the chronic nature of low-risk MDS, that it, even during the watch and wait period, or the issues that come along with that and their quality of life, and for their caregivers as well that may be concerned about that?
Sure. So I think that's why it's important to be, have a very open conversation with your doctor, because oftentimes we'll want to know, what kind of support do you have at home? So if you don't have a lot of support, it's important for the doctor to know that, because there may be additional resources they could suggest to you to build that support network. But some patients still, even with that, don't necessarily have a good outreach. So in our center, we do have the fortune to have a case manager, a social worker that can help us try and improve quality of life in those patients. And also, being a comprehensive cancer center, we have what's called a palliative care department. So they also help us manage, if present, symptoms that we may not be improving upon with our therapy that are related to the MDS. Other things like anxiety and depression that can sometimes be made worse with given a diagnosis like this. They help us support patients in that way. So there are a lot of resources that you can use, and I think some of those websites like the Aplastic Anemia and the MDS Foundation, as well as Leukemia and Lymphoma Society, can also offer resources for patients.
Thank you. Do the doctors at Roswell Park meet together to discuss patient cases?
We do every week.
And here's another online question. Is it acceptable to have wine at dinner with MDS?
So I guess that depends on how much wine. And it also depends, honestly, on the medications. Like, for example, I was mentioning patients that are neutropenic that may be on medication to prevent fungus infections is processed through the liver at a high degree. So in that situation, even a little bit of alcohol can irritate the liver. So personally, I have no problems with that, but I do think you should confide in your doctor and ensure that there's no interactions with your medications.
Thank you. Are there any other questions from inside the room? Okay, we don't have any more online, so thank you so much, Dr.
You're welcome.
Przespolewski.
Thank you.
Thank you for sharing your time and expertise with us. If you would like to watch the session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us at any time in 3 ways. You can send an email to help@aamds.org. You can call the AAMDSIF helpline at 800-747-2820, extension 2, or you can submit a question on our Facebook page. If you are watching online, please take a few minutes to complete the session survey. Your input is important to us and helps us plan future educational programming. This concludes the educational sessions at this conference. We hope you will join us at 2:30 for the support groups. If you are online, please use the Zoom link provided to join. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family, as we have for the past 39 years. This concludes the session.